Hello, welcome to Sonography Radiology Training channel. This series of videos is about umbilical cord imaging. This is the first video in this video series with title of Normal Umbilical Cord. The outline of this presentation includes introduction, umbilical cord development, umbilical cord morphometry, including umbilical cord length, and umbilical cord cross-section or diameter. At first, introduction. The umbilical cord is a direct continuation of the fetal cardiovascular system, anatomically bridging between the placenta and the fetus. This structure, critical in human development, enables mobility of the developing fetus in contrast to the placenta, which anchor to the uterine wall. The umbilical cord assures a flexible delivery system of both oxygen and nutrients with concurrent removal of carbon dioxide and other waste components or elements toward the placenta and away from the tethered fetus, while concurrently enabling the fetus to develop in an almost unrestricted aquatic environment, facilitating pulmonary and joint extension flexion development. It's interesting to compare this robust life support system to the system devised initially by the NASA to sustain human life during the first extravehicular activity in space, which clearly appears to have the mimicked nature in this aspect. Evaluation of the umbilical cord is important in part because umbilical cord abnormalities are associated with approximately 20% of stillbirths. Furthermore, precise placental histological criteria accompanying restriction of umbilical cord follow have been established, which enable unique determination of potential umbilical cord compromise, which previously unsuspected prior to histological assessment. Umbilical cord development. The oval line of reflection between the amnion and embryonic ectoderm, famous as amnio-ectodermal junction, is the primitive umbilical ring. At the 5th week of development, the following structure passes through the ring. The connecting stalk containing the lentis and umbilical vessels consisting of 2 arteries and 1 vein. The yolk stalk or vitelline duct accompanied by the vitelline vessels, and the canal connecting the intraembryonic and extraembryonic cavities. The yolk sac proper occupies a space in the chorionic cavity, that is the space between the amnion and the chorionic plate. During further development, the amniotic cavity enlarges rapidly at the expense of the chorionic cavity, and the amnion begins to envelop the connecting and yolk sac stalks, crowding them together and giving rise to primitive umbilical ring. Distally, the cord contains yolk sac stalk and umbilical vessels. More proximally, it contains some intestinal loops and the remnant of the lentis. At the end of the 3rd month, the amnion has expanded so that it comes in contact with the chorion, obliterating the chorionic cavity. As you can see, at the end of the 3rd month, the chorionic cavity disappeared. The yolk sac then usually shrinks and is gradually obliterated. The abdominal cavity is temporarily too small for the rapidly developing intestinal loops, and some of them are pushed into the extra-embryonic space in the umbilical cord. These extruding intestinal loops form a physiological umbilical hernia. This ultrasound image of a fetus at 10 weeks gestation showing physiological herniation of the midgut into the umbilical cord. At approximately the end of the 3rd month, the loops are withdrawn into the body of the embryo and the cavity in the cord is obliterated. When the lentis and the vitelline duct and its vessels are also obliterated, all that remains in the cord are the umbilical vessels surrounded by the jelly of Wharton. An additional safety mechanism of the umbilical cord is Hertel's anastomosis. This 1.5 or 2 cm shunt between the umbilical arteries is positioned within 3 cm of the placental cord insertion. Umbilical cord morphometry. At first, umbilical cord lengths. The mean length of the umbilical cord is approximately 55 cm, and measurements above 80 to 100 cm considered as excessively long, and below 35 to 40 cm excessively short. Both excessively long and short umbilical cords, respectively, have been associated with an increase in adverse prenatal outcome. Excessively long umbilical cords clearly predispose to cord entanglement, including true knots, knuckle cords, and other complex entanglements. Also of interest is the possible association of excessively long umbilical cords with an increased risk of fetal growth restriction and marked fetal thrombotic vasculopathy. In contrast, excessively short umbilical cords are less common and often are associated with fetal anomalies including Pena-Shorkier sequence or fetal hypokinesia-akinesia sequence, New-Laxova syndrome, other rare constructive dermopathies, and arthrogryposis. Interestingly, all of these conditions are associated with decreased or absent fetal movement, further strengthening the association between the fetal movement and overall umbilical cord lengths. Additional fetal anomalies associated with short umbilical cord include limb-body wall complex or body stalk anomaly and ectopia cordis. Short umbilical cords in the absence of associated fetal anomalies have been associated with a significant increase in cesarean and operative vaginal births and also placenta abruption and uterine invasion. Rare cases of absent umbilical cord or accordia have been reported and are usually associated with structural fetal anomalies including abdominal wall defects and limb-body wall sequence. In contrast to other fetal organs like the placenta or the uterine cervix, the umbilical cord is seldom depicted or tracked sonographically throughout its entire length. This reflects a number of reasons. In general, difficulty, not surprisingly, is encountered tracking longitudinal, essentially two-dimensional free-floating space within a three-dimensional volume that is the gestational sac. In addition, the fetus, especially in the late second and third trimesters, often obscures considerable segments of the umbilical cord, which are thus inaccessible to sonographic interrogation. Sonographic depiction of the entire umbilical cord has rarely been reported. These reports have mainly been limited either to the first trimester of pregnancy or of rare cases involving markedly shortened umbilical cord lengths. Furthermore, it appears likely that depiction of the entire length of the umbilical cord may be within reach in the future with increasing application of new emerging imaging technologies, for example CT and or MR imaging and 3D computer-assisted reconstruction techniques, which may enable depiction of the umbilical cord positioned behind the fetal body inaccessible to transabdominal sonography. In any event, although governing body guidelines currently suffice with the directive that prenatal sonographic assessment should include depiction of the fetal and placental insertion points of the umbilical cord, all visible portions of the umbilical cord should be assessed in order to potentially depict abnormalities of this organ critical in human development. Umbilical cord cross-section or diameter. This study assessing first trimester sonographic umbilical cord diameter and growth of the human embryo noted that the umbilical cord diameter increased gradually between 8 and 15 weeks gestation. In addition to significant correlation between the umbilical cord diameter and gestational sac, also they found this correlation between umbilical cord diameter and chromosome length and also biparietal diameter. No correlation was noted between umbilical cord diameter and birth weight or placental weight at delivery. Among patients who had a miscarriage and preeclampsia, the umbilical cord diameter was 2 standard deviations below the mean in 3 cases of both of them. Interestingly, this same group of investigators noted that among many patients undergoing routine sonographic evaluation between 10 and 14 weeks gestation, the number of fetuses with an umbilical cord diameter above the 95th centile for gestational age was higher in the presence of fetal or placental chromosomal abnormalities than in normal fetuses. Thus, the first sonographic umbilical cord morphology or diameter was considered to identify a subset of fetuses at increased risk of fetal chromosomal abnormalities, a finding that confirmed by later studies. Umbilical cord diameter measurement technique. In first trimester screening, in addition to measurement of chromosome length and nuchal translucency, we also can measure umbilical cord diameter as outer to outer border at the maximal magnification. 2 measurements can be made in a free loop of the umbilical cord from the long axis view, and the average of the 2 are calculated. Now, please pay attention to these final teaching points. Evaluation of the umbilical cord is important in part because umbilical cord abnormalities are associated with approximately 20% stillbirths. Both excessively long and short umbilical cords, respectively, have been associated with an increase in adverse prenatal outcome. Short umbilical cords, in the absence of associated fetal anomalies, have been associated with a significant increase in cesarean and operative vaginal births, placental abruption, and uterine inversion. In any event, although governing body guidelines currently suffice with the directive that prenatal sonographic assessment should include depiction of the fetal and placental insertion points of the umbilical cord, all visible portion of the umbilical cord should be assessed in order to potentially depict abnormalities of this organ critical in human development. Like nuchal translucency, first trimester sonographic umbilical cord morphology or diameter should be considered to identify a subset of fetuses at increased risk of fetal chromosomal abnormalities. Now, I suggest 2 others of my videos that are close to this video in terms of matter. And thank you for your attention.